What is the purpose of this video? The purpose is to give you an overview of our service and our team, to provide you with information about the different types of surgery, the health benefits of weight loss, explain how these can cause weight loss, what to expect at our one-stop clinic day, the benefits and the risks, and what to expect from and after surgery. The purpose is also to explain the patient pathway at Maidstone and Tunbridge Wells Trust.
One-stop assessment clinic. You will attend our one-stop assessment clinic where you will be seen and assessed throughout the day by various members of the team, including the dietitians, the psychologists, the surgeons, the anaesthetists and the clinical nurse specialists, CNS for short. The endocrinologist sometimes gets involved with patients that are diabetic or have thyroid issues, but he does not attend every clinic. In some circumstances, all of the team may not be available on the day you come to clinic, and we may ask you to come back and see that particular member of the team so that you've been assessed by everybody. You will also receive a letter regarding your appointment, and it will have a QR code or a telephone number asking you to book a blood test prior to your appointment. This can be done on the day of your appointment. It does not have to be done earlier than the appointment. So if you have an appointment, for example, at 10 o'clock, if you try and book it in any time between 8 and 10, that will be absolutely fine. These bloods are to assess things such as your kidneys, your liver, but also nutritional bloods such as vitamin D, vitamin B. We're also looking at diabetes and thyroid tests. And this will allow us to sort out any issues that you may have, such as reduced vitamin D level prior to surgery. The clinical nurse specialist will also be doing an ECG, which is a reading of your heart. So we ask you to wear loose clothing as we need access to your knees, although we're very happy for your trousers or skirt to be removed. And we will also ask you to remove your top half, and ladies, you can keep your bra on. And this will be assessed by the anaesthetist as part of the day. Following your one-stop assessment clinic, we will have a multidisciplinary meeting to establish whether we feel you're appropriate for surgery or not. It may be we decide that we don't feel you're appropriate for surgery at all and we refer you back to your GP. It may be that we feel you are appropriate for surgery, but we don't feel it's something we can do at our hospital, maybe due to complex issues, and we'll refer you to another hospital such as University College Hospital, London, that we work closely with. It may be you are appropriate for surgery, but you do need further investigations. So it could be to an external service or at another hospital, or just another service within our hospital, such as the endocrinologist or the haematologist or cardiologist. It could be that you need an endoscopy to look at your reflux symptoms, and so we'll add you to the waiting list for that. It may be that you need sleep studies, so some of these can be carried out at Tunbridge Wells depending on your catchment area, but others have to be referred to external hospitals. And it could be that you're having investigations at your local hospital, and we'll ask for those to be completed and the results sent through. If the investigations are being carried out at other hospitals, obviously we have to wait for those to be carried out until you can be added to our waiting list. If it is something just such as an endoscopy, we will add you to the waiting list and monitor it within our hospital. It could also be that we're very happy for you to be added to our waiting list for surgery, and that's what we will do, and you will be contacted and a time frame for this will be discussed at the time. So just an overview of the multidisciplinary team involved in care. So there is the surgeons, the anaesthetists, the clinical nurse specialists, the psychologists. Some patients will see the endocrinologist. There's the dietitians, the MDM coordinator, an administration team involved in booking surgery, etc. There's nursing staff, theatre staff, patients, obviously, if you go to an external centre or visit another discipline, they're all involved in your care and we work closely with them. So some frequently asked questions regarding the one-stop assessment day. You can have your blood test done on another day if needed, but ideally we ask you to book it in on the day for the day of your appointment. But please don't book it in during an appointment time, as it will delay other patients during the day. If you can't book in for that day, don't worry too much, and we will try and fit you in around your clinic appointments. You will be in the hospital for most of the day, so make sure you bring some lunch with you. There is a Costa coffee on site and a WH Smith. If you were to have a large gap throughout your day, you could possibly wander over to the Knockcuts Garden Centre opposite, but otherwise we would advise you just to stay on site throughout the day. And you can bring somebody with you to clinic, and it may be you're happy for them to attend all your appointments. It may be that you want them just to sit in the waiting area while you attend your appointments, or you can pick and choose. So some patients won't want them in, for example, in the psychology assessment, where you can ask your loved one or your friend or whatever to wait outside. So yes, please bring somebody with you if you'd like.
So the surgery at Tunbridge Wells Hospital is performed laparoscopically. We only convert to open surgery if there are any complications.
So on to the types of surgery. This is one of the types of gastric bypass, and this one is created where surgical staples are used to take a small part of the stomach and create a small pouch. This pouch is then connected to the small intestine, which bypasses the rest of the stomach. Food will pass from the top section, the little pouch of the stomach, directly into the small intestine by bypassing the remaining stomach and duodenum. This creates a combined restrictive and malabsorptive procedure, which means you won't absorb everything that you eat. This is a slightly different type of bypass, often called the mini bypass. It's known as a one anastomosis, and anastomosis just means join. So in this one, the stomach is stapled down to create a long gastric pouch. The rest of the stomach remains there, but food doesn't go into it, and the small intestine is then connected to the bottom of the pouch. This replumbing means that the bile contents can sometimes pass into the stomach and the food pipe. And onto gastric sleeve. And a sleeve gastrectomy is where a large percentage of the stomach is completely removed, leaving it much smaller than it was before. It generally reduces the size of the stomach to around 75 to 80% smaller, and it means you can't eat as much as you could before surgery, and you'll feel much fuller much sooner. The operation also means that you reduce the hunger hormone, ghrelin, so you won't want to eat as much.
Complications immediately post-operatively. We do our best to reduce these and prevent these, but the following can occur. Blood clots in the legs or the lungs due to reduced mobility and increased weight following the surgery. We provide you with anti-embolic stockings, which you'll need to wear for at least 2 weeks, day and night. They can be removed for showering and then must be reapplied. Anticoagulation injections will also be given after surgery, which will be once or twice a day for 2 weeks. We can teach you on the wards how to provide these, or you can have friends or family giving these injections. Wound infections can occur after surgery. If there's any concerns, such as the wound is red or hot or oozing, we'll ask you to contact your GP practice and get the practice nurse to have a look. And maybe take a swab and some antibiotics, or you can send us some photographs if you're concerned. You can get a leak in the gut. This normally occurs in the first few days or weeks following surgery, where there is a chance that food can leak out of the abdomen, causing a serious infection known as sepsis. You can get a blockage in the gut, sometimes in the stomach, or the small intestine can become narrowed or blocked after weight loss surgery. The symptoms of this is difficulty in swallowing, vomiting or abdominal pain. Constipation is a common side effect of surgery due to the reduced oral intake and some of the pain-killing medications. We send you home with medications that will help this, but please obviously contact us if you have any concerns. and death is a rare complication but can be caused by any of the above conditions.
So there's many health benefits of surgery. So there's an improvement or remission of obesity-related conditions. These commonly might be diabetes, hypertension, high cholesterol, sleep apnea and the need for CPAP, having mobility and joint issues. Often it can help improve the symptoms of polycystic ovary syndrome and increase chances of fertility, although pregnancy should be avoided for at least 18 months. Really, there's a significant quality of life, improved life expectancy, and people feel better about themselves afterwards after losing weight. So just to give you a little example about expected weight loss, most people can expect to lose between 50 and 70% of their overall excess weight. So if we're looking at Mrs. Brown, she's 1.65 meters tall and pre-surgery has a weight of 130 kilos. She therefore has a BMI of 47.75 kilos per meter squared. Her ideal body weight of a BMI of 25 is calculated by the sum 25 times her height in brackets, and that leaves us with 68 kilos. Her excess weight would therefore be considered to be 62 kilos, 130 kilos subtracting her ideal body weight. So just to give you a little example about expected weight loss, most people can expect to lose between 50 and 70% of their overall excess weight. So if we're looking at Mrs. Brown, she's 1.65 meters tall and pre-surgery has a weight of 130 kilos. She therefore has a BMI of 47.75 kilos per meter squared. Her ideal body weight of a BMI of 25 is calculated by the sum 25 times her height in brackets, and that leaves us with 68 kilos. Her excess weight would therefore be considered to be 62 kilos, 130 kilos subtracting her ideal body weight.
Contraception and pregnancy after surgery. Bariatric surgery can often lead to improvement in fertility issues such as polycystic ovaries, and it is therefore important to consider contraception after surgery. Following weight loss surgery, it is crucial not to get pregnant within the first 12 to 18 months, but essentially up to 2 years, as this can cause nutritional deficiencies in both the mother and the fetus during this time due to the extreme weight loss following surgery. There can also be complications such as internal hernias following a gastric bypass, which is why we tend not to offer bypasses to women who have not yet had their families or of childbearing age. Following bariatric weight loss surgery, we know that the contraceptive pill is not effective and absorbed following a bypass, and we are not sure of how effective it is following the gastric sleeve. So therefore we would recommend other forms of contraception such as an IUD, which is the coil, injections, hormone implants, and if people do want to consider still taking the contraceptive pill with the sleeve, they would need to use other effective methods such as the barrier method, so using condoms, but ideally they should be using the injection, the implants or the coil. There can be many complications and long-term complications following weight loss surgery. Here are a few of the common ones. So there can be malnutrition from weight loss surgery, as it's harder to absorb vitamins and minerals via the gut, and there's a risk of a patient becoming malnourished. So that's why it is essential that you have lifelong vitamin supplements as advised by your bariatric team. Gallstones are quite common, especially in the first 1 to 2 years after weight loss surgery. This is because weight loss can cause changes in the saturations of bile with cholesterol, and this can form crystals which then form gallstones. So some patients will get pain, which may be nothing directly to do with the surgery, but it could be to do with gallstones. Excess skin obviously can be an issue if you're losing a lot of weight. Currently, this is not removed on the NHS. so may need surgical removal privately or for it to remain in situ. Hair loss can occur, especially within the first 6 to 9 months. This is due to the rapid weight loss. It's not uncommon, and it might just be a bit of thinning at the front of the hair, or people might notice when they're brushing or shampooing that more hair is coming out. If you continue to eat a healthy, balanced diet and take the vitamins and minerals supplied, then this will allow the hair to return to normal. Dumping syndrome is a common side effect after weight loss surgery. Up to 75% of people who have had gastric bypass surgery will experience some dumping syndrome, and this is often caused by eating and drinking too much sugar, or eating too quickly, eating food and drink together, or large quantities of food, carbohydrates for example. It can have multiple effects, such as needing to have your bowels open as soon as you've eaten or within half an hour. It can make you feel a bit shaky, like you're dropping your blood sugars, and some people regurgitate their food.
My name is Dr. Elizabeth Samuel. I'm the clinical psychologist for the Bariatric service, and I'm going to speak to you very briefly about a few things that you can do to be aware of your psychological well-being whilst undergoing the bariatric surgery programme. It's really important that you look after yourself psychologically. Bariatric surgery involves making a permanent alteration to your body and involves lots of lifestyle changes that you will be committing to for the rest of your life. So it's really important that you feel ready for this emotionally and physically. There are some simple things that you can do to make sure that you feel psychologically ready for the surgery. One of those things involves having a really good knowledge and understanding of what the surgery itself involves, the changes that you'll be committing to, and the unexpected side effects that can come up as a result of having bariatric surgery. There's a fantastic book by Denise Radcliffe called Living with Bariatric Surgery that is available on Amazon. It's very digestible, very easy to read, and it gives a fantastic overview of not just the surgery, but of what life tends to look like after the event. As well as doing reading on the topic, you can attend the education sessions on offer and speak to others who have undergone the surgery in order to skill yourself up in having the essential knowledge that you need. The more you know about what you're entering into, the easier the transition will feel. Before and after the surgery, it can be really helpful to make sure that you draw in sources of support. Making sure that you have time off and understanding from your boss and your colleagues is really important, as well as using your friends and family, not just for the emotional support, but for practical support for things like childcare and lifts. And it's really important as well to speak to your dietitian and nurse, both before and after surgery, if any concerns come up for you. Try to time the surgery for a time in your life when there's minimal other stresses going on. Things like moving house or changing jobs or coming off antidepressants can be a really big challenge to manage, and something that you don't need when you're undergoing a surgery and learning how to eat all over again and what this new stomach means for you. And remember that there's a really natural adjustment process to undergoing a big life change like a bariatric surgery, where emotions will feel up and down for quite a while. If you were concerned that your emotions were down for a long time and you were worried that you weren't quite yourself, it's really important that you speak to someone about that, whether that be your GP, your dietitian or your nurse, or you can actually even self-refer to your local talking therapy service. There's no need to ask your GP to do this and wait for an appointment. You can look online, find your local service and fill in an online form. It's very easy and quick, and they can offer you support really quickly. If surgery is agreed and you are placed on the waiting list, it's really important to make use of that time and maintain the healthy changes that you've already worked so hard to achieve. Eating healthily, getting good sleep and exercise always helps with the recovery period, and working on smoking and reducing alcohol intake is really key prior to surgery. Make sure that you follow all the instructions to help you feel properly prepared for surgery and the advice that you've been given by your bariatric team. And if you've been working on issues to do with emotional eating or binge eating, make sure that you continue to use the time before surgery well to address any further issues related to these, so that these problematic type behaviours don't undermine you following your surgery. Lastly, if you are undergoing any counselling or mental health support, keep that going, as it's a great source of support to have both prior and after your surgery.
So what can you do following this session? You can stop smoking, e-cigarettes or vaping if that's what you're currently doing. The surgeons will not operate if you are smoking, as this can cause issues with healing and leaks after surgery. And continue your weight loss journey. So some people find that when they're discharged from the Tier 3 service and waiting for an appointment to come and see us in our one-stop clinic, that they have put some weight on. So if you get back on the weight loss journey and try and lose a bit more weight before you come and see us, that would be great. Increase your activity levels as able. We know some people are waiting for joint replacements or have pain issues, but if you can increase your activities, that will prepare you well for any surgery. And have a think or a read about what surgery you might feel is appropriate for you, and discuss this at your one-stop clinic appointment. The surgeons will discuss what they feel is appropriate, but if you come with an idea and why you feel you want that surgery, obviously that's a discussion that can be had on the day. So if you're accepted for surgery, you will get a call following a multidisciplinary discussion. This will be once you have seen all the disciplines from the team. So if you have to come back for a catch-up appointment, it will be following this. If you are accepted for surgery, you'll be added to the waiting list, and it's important to continue to aim to lose weight and to remain as active as possible, as this will benefit you for surgery. If you take medications such as ibuprofen or naproxen, which are non-steroidal drugs for long-term pain conditions, then contact your GP and discuss alternatives, as the ibuprofen and naproxen can cause ulcers in the GI tract, and obviously we need to avoid that, so you'll not be able to have these medications after surgery. Make sure that you start on your alternative medications prior to coming into hospital, so that you know from your long-standing condition that your pain is under control. The team will be in contact with a date for surgery and then an appointment for bloods and swabs in the clinic prior to theatre.
So the liver shrinkage diet is something that we ask all patients to undergo before surgery. The liver is quite a large organ that sits in the upper right quadrant of the abdomen, and as you can see from this picture, it sits over the part of the stomach or the first part of the bowel that would need to be accessed to be able to carry out the surgery. Most people considering bariatric or metabolic surgery will have a larger liver, usually fatty, whether it's diagnosed or not. We assume that everyone will have some element of that. So the liver's function has many functions in helping to clean toxins out of the body, but the main function that we worry about now in this context is that it's used to store lots of energy. So what we need to do to complete the surgery, the liver needs to be shrunk so it can be moved out the way. We need to turn it from quite a large hard organ to being quite a soft floppy one that can be moved. And the way we do that is we ask you to follow one of our diet options for the liver reduction. So you can do a milk and yogurt option or a food option, and both options provide less than 100 grams of carbohydrate. They're low in fat and between 800 and 1,000 calories with moderate protein. Once you choose one, you can't switch between them, you need to stick to it. And it needs to be stuck to for 2 weeks as a minimum, but potentially longer if you have a higher BMI and on discussion with the surgeons. Some people carry a little bit more weight around their tummy, and therefore we might need to make that a little bit smaller. Or if there's someone who's having a bypass, we might need a little bit more space in the abdomen, so it might be that you need to do this for a month. But you'll be advised by your team how long and when to start, and you'll have a phone call to check that you're okay with it a week or two before. We'll also send your GP a letter about soluble or liquid or crushable medications for your routine ones, and you'll need to collect that prior to surgery and bring it to hospital with you. Anything that we start in the hospital during your surgical stay with us, we'll provide. While you're on your liver shrinkage diet, there are some things that you would be recommended to do. So if you are a carer, either for pets, children, or others like looking after another relative, you need to make provisions for not being able to drive for 2 weeks. We'll have sent a letter to your GP to make sure that your regular medications are in a liquid or crushable form. And you need to chase them and make sure you've got them. And think about getting some liquid or soluble paracetamol. Think about the first 2 weeks after surgery, so you can get a chewable multivitamin and have a few days of protein-rich fluids. Maybe you might think about some food prepping, so the pureed stages or minced and moist can be frozen from leftovers. And be aware that your bowel habits might change. Some people may require some Imodium or loperamide over the counter, or maybe some lactulose or senna to help with their bowels.
On the ward after surgery. When you wake up, you will be wearing anti-embolic stockings. You will also have some intermittent pneumatic compression boots on, and these are boots that wrap around your calf and squeeze in and out gently to prevent blood clots. They will be removed by a nurse as you start to mobilise, and we encourage you to get up as soon as possible and as soon as comfortable to do so to prevent blood clots, chest infections, and also to help relieve that trapped gas pain. The nursing staff may also give you a Voltaren suppository in the evening before you go to sleep. This is a really good painkiller and it can help with discomfort, which will aid you to sleep better. You'll go home with 3 of these suppositories as it is just a short-term treatment. You'll be asked to sip fluid slowly before going home, and you may have some milk or very thin soup. Just aim to not take too much air in when swallowing. You'll be seen by the surgeon and other members of the bariatric team the next morning, who will review your wounds and discuss post-operative care and advice. Your wounds may be glued with a soluble stitch internally. Sometimes this stitch can protrude out slightly, but be assured it will dissolve, it just takes a little time. The wounds may also have clips in, which will need to be removed by your practice nurse in 10 to 14 days. And you will need to arrange this appointment. On the ward continued. You may find that the first time you pass urine, it could be green in colour, which is due to the surgeons using a blue dye to check during your surgery that there are no leaks. Early mobilisation will help prevent chest infections, muscle weakness, pressure sores, and blood clots. And this is why the nurse on the ward will be encouraging you to mobilise as soon as possible after surgery and when you're comfortable to do so. Practicing deep breathing exercises will also help to prevent chest infections. A combination of 3 to 5 deep breaths, then huffing 2 to 3 times, as if you were huffing and steaming up a bathroom mirror. If you need to cough, you can use a rolled up towel or pillow on your abdomen for comfort. The nursing staff will explain how to give your blood thinning injections to yourself, or if you've nominated a relative or friend, they will also be able to explain to them. You will have your bloods checked the next morning, and all being well, you will be discharged home. Medications provided on discharge. These are the medications that you will be sent home with, and a nurse on the ward will be able to explain to you about them before you go home. You'll be sent home with an anti-sickness medicine, and this will be in a liquid form, and it is usually metoclopramide, and this is to be taken if you're feeling nauseous. Pain relief, you'll be given tramadol or codeine, usually we give tramadol, and the Voltaren suppositories, which is also called diclofenac, and as I said before, there will be 3 of those. You will need to purchase your own paracetamol, which will need to be in a liquid or dissolvable form, as this will not be supplied. You will be given laxatives, and it's a mild laxative called lactulose, and you need to use this when required. If you are starting to experience loose stool, then to stop using it and only use it if you need it. You'll be given your blood thinning injections, and this is dalteparin, and it's for 2 weeks. You'll also have an antacid, which is lansoprazole, and this will protect your stomach, and it needs to be taken for a minimum of 6 months. This can change to another suitable medication like omeprazole or esomeprazole when you are able to have capsules or tablets.
So on to the diet after surgery. So it's broken down into 4 stages. The first 3 are 2 weeks per stage. It can be longer than 2 weeks, but not shorter. So the first stage is weeks 1 to 2, and it's thin liquids only with no lumps. And the definition of a liquid is if you pour it on a table, it forms a puddle, no mounds. And moving on from that, you go on to stage 2, which is usually weeks 3 to 4, and that's puree texture. So think very runny mashed potato or baby food consistency, but you're not actually allowed to have baby food. Stage 3 is normally weeks 5 to 6, and that's soft texture. And think about cottage pie consistency, so meat and gravy with some mashed potato. And stage 4 is normally from around week 7 onwards, and that's normal, regular consistency of foods within what we would consider a normal, varied, healthy diet. We don't want people to have alcohol for at least 6 months, but ideally a year, and that's due to the change in your anatomy. You might absorb things differently and become more intoxicated. And we don't want people to have fizzy drinks because they can increase your bloating or discomfort, and there's some evidence about them stretching anatomy in the long term. So in stage 1 with your smooth liquids, the purpose of this is to allow your new sized stomach to heal and usually last 2 weeks. We will tell you on the ward if you can start all of your liquids. They should be completely smooth, and you need to sip them very slowly and try to understand where you feel full. When you're drinking, try to tip fluid into your mouth rather than slurping, as that will introduce more air and more gassy, bloating feeling. And really, we want you to be aiming for a pint of protein-rich fluids and then making the rest of your fluids in the day up to about 2 litres. So these are just some examples of protein-rich fluids. There's a huge variety of protein-rich fluids in products, in different things you can do. So really, your pint of protein-rich fluids can be made up of having 3 of these. So anything that's a high protein drink, you can have that 3 times a day, and that will be adequate for you in your smooth liquids. If there's any particular products or anything you had any queries about, your dietitian will be able to help you with that.
When you move on to your pureed diet from your liquids, one of the dietitians will ring you from our team to make sure that you're okay with your liquids and safe to move on. And they'll also talk through the rest of the stages at that point. Your pureed diet needs to be completely smooth and completely blitzed up. There's no need to buy any fancy expensive liquidizers, just a cheap stick blender and a jug will be absolutely fine. Generally, we need people to make sure that they are having their protein first, then any fibrous fruit and vegetables, and then carbohydrates last. These are just some examples of foods that you might have at the pureed stage. This isn't a prescriptive menu, so you don't have to follow this, but it's just to give you some ideas of the sort of things that you might be able to have for each of your meals and a snack throughout the day. And just be very sensible about it. Sometimes people might prepare the food beforehand, before they have surgery, blitz it down and freeze it, or they might look at family meals that they can make that they can take parts of and puree down. After you've progressed from your pureed food, you move on to the soft and moist for stage 3. This is for around 2 weeks' time, although some people stay on it for a little bit longer. All of the soft and moist foods should be well cooked and not require a knife to eat. They really should be fork mashable, and the sort of thing that you might have would be well cooked vegetables or mince in gravy or fish in sauce. Generally, what I do say to people is if you can imagine you've got no teeth and you've got no knives in your house, that's generally the right consistency. And we want to continue to balance meals and aim for your protein, then your fibrous food, and then small amounts of carbohydrate, 3 times a day with 2 to 3 snacks. Again, these are just examples of things that you might have while on the soft and moist stage, but you can see the difference between the pureed stage and this one, where you might be able to have beef mince rather than blitzed up bolognese. You could have something like slow cooked chicken thighs that are much softer, moister, and be able to have baked beans or some soft scrambled egg. So once you can tolerate soft and moist foods, you can move on to your regular, varied, healthy diet, and your stomach should be sufficiently healed to tolerate this regular eating pattern. Really, you should be trying to choose leaner, less fatty options of protein with plenty of vegetables, salads, and those sort of things. And if you have room, then having some small portions of carbohydrates. Again, this is just an example menu of the sort of foods that you might have ongoing. You might be able to have something like a poached egg and beans for breakfast, or some low-fat Greek yogurt that provides your protein. And then for lunchtime, a bit of preparation perhaps if you're going into the office, some tuna or some chicken, some feta, broccoli, green beans. And then the evening meal, you can use things that the rest of the family are having, if that's the way your household is set up. And it's really important to try and think of some snack ideas that are protein rich as well. This is more for reference for later, but these are some examples of some 10 grams and 20 gram protein sources. You'll be told by your dietitian team what your aim should be, and that might be slightly different based upon the surgery that you have and your height and your other medical conditions. But these are the examples of what you might find. Generally, you'd want to base your meals around your 20 gram protein sources and think of your 10 gram ones as snacks. But everyone's lifestyle is different, and we have to find a way that works for you. The idea of bariatric surgery is not to make sure that you're having a completely restricted diet. And in fact, if you have a normal diet as the people around you, but modify it to suit you and your requirements, you will find it easier to shop, to food prep, and generally have a better outcome. So instead of a beef burger and fries, you might have a slider and salad. Make it much smaller, reduce the carbohydrates in the bun, and swap the fries for a bit of salad. Same as having a cottage pie. Save some of the filling if you make it yourself. A little bit of mash, making your own ramekin with added veg and less potato. These are just examples again of things, but it's about getting into the mindset of thinking, what things can I have, what things can't I have, and what things can I have that everyone else can have in the household, or if I'm going out to eat, what other things can I have, and how does that fit in with my requirements, not everyone else's. At week 6 to 7 post-op, you can now go back onto taking tablets for your regular and any new medications. You now need to start your vitamin regimen, and you need to contact your GP for your B12 injection. You should be starting to gently increase your exercise and activity, remembering that everyone has different levels of starting points for this. Generally, we find that sometimes people can get a bit obsessed with their weighing habit, and that can be quite unhelpful. We try and say to people, don't weigh more than once a week because you won't see significant meaningful changes, and that allows you to track yourself over a longer period of time. And sometimes some of our patients don't even weigh themselves at all other than when they come and see us. Some people do take photos, and what can be useful is to do so in the same place for context. So if you take a picture on a train, in a bar, at the beach, it's all very different backdrops, different lighting. So if you choose somewhere like the bottom of your stairs or in a doorway at home, it gives you some context. Often people find that a clothes size is a good marker as well. And measurements can be useful, but again, don't overdo it because people can become obsessed by it. Once a month is completely sufficient. Generally, increasing your muscle mass may mean your clothes and measurements change, but your weight might not go down as quickly as you increase muscle and reduce fatty tissues. So just be aware of these things. After surgery, it's very important to make sure you commit to taking a vitamin and mineral regimen daily. This is to prevent deficiencies, either because you don't get enough from food or because you might not absorb as much, or a combination of both. In this area, GPs will not prescribe vitamins or minerals except for in exceptional circumstances, so they are needing to be bought over the counter. There are bariatric specific ones, but they are very expensive, and generic versions do exactly the same and will cost you somewhere between £100 and £140 a year in total. We really need you to commit to monitoring by having blood samples taken. So the hospital will take all the blood samples required over the 2-year period. Your GP is not required to do this. This is a list of vitamins and minerals required for a gastric bypass or a gastric sleeve. And what you will need is 2 tablets of a generic multivitamin from any of the big supermarkets or Superdrug or Boots. Iron tablets. Ferrous fumarate is the preferred, most gentle on your stomach version, but you can also use sulfate or gluconate. If you're having regular periods, then you'll need it twice a day, and we'll monitor how your bloods are doing. You also need to make sure that you're getting adequate calcium and vitamin D. And there are some examples of that. If you do have a history of kidney stones, then you need to make sure you tell your dietitian so that we can give you a slightly different preparation. And your GP, as mentioned before, needs to give you your B12 injection every 3 months. It's very important to make sure that you are spacing out your iron and your calcium as they get absorbed in the same way, and therefore you might not be getting the benefit of both of them.
When to contact your team. If you are struggling with regurgitation, vomiting or excessive nausea and you're not able to keep anything down including sips of fluid and therefore you're liable to get dehydrated, please contact your team. If your pain is not settling, give us a call and we can talk to you about your pain relief and where your pain is. If you need advice regarding your bowels, if you're very constipated and the medication doesn't seem to be working, or you have diarrhea, please let us know. If you're feeling very tired, weak, or just not right in yourself. If you're struggling with introducing the next stages of the diet or having problems swallowing. If you're having problems swallowing, let us know. If you're struggling with introducing the next stage of your diet, we would always advise you to slow down and introduce the next stage slowly, but contact us if you need support with this. If you're experiencing high temperatures and shiver shakes, signs of sepsis, severe abdominal pain, we expect you to be sore, but you get a sudden onset of pain, bleeding from somewhere you shouldn't be bleeding, vomiting where you can't keep anything down, sudden shortness of breath, or pain, redness and swelling in your calf, which is an indication of a blood clot, then please attend your local A&E department. Do not leave a message on our answer machine, as we obviously may be busy and may not get back to you for a while.
Post-operative follow-up. This is when you will be seen or have made contact with following your surgery. You will be seen on the ward prior to going home by your surgeon and your clinical nurse specialist and dietitians if available on the day. You'll be called after 48 to 72 hours by the clinical nurse specialist. And then you'll be called again at about 2 weeks following your surgery by the dietitians, who can then give you advice about transitioning into your next stage of the diet. Your first face-to-face follow-up appointment will be at 3 months, and this will be with the clinical nurse specialist and the dietitian. Bloods will also be taken after that appointment and your weight will be recorded. You will then be called at 6 months by the dietitian and bloods will be requested 2 weeks prior to this appointment. So you will need to come into the hospital, either Maidstone or Tunbridge Wells Hospital, to have your blood tests prior to the appointment. At 1 year, you will be seen face to face by the dietitian and the clinical nurse specialist. And then at 18 months, it will be another face-to-face appointment and it will be a clinic with a clinical nurse specialist and weight will be recorded. At 2 years, this will be the last stage of your journey with us and you'll be seen by your surgeon, clinical nurse specialist and dietitian. And all being well, we will discharge you back to your GP. Bloods will also be taken and weight recorded at this appointment.
You'll be asked to complete wellbeing questionnaires at the 3-month follow-up as well as 6 months, 12 months and 2 years after surgery. These are really important questionnaires to complete as they help us identify any post-surgical support needs that you have, which relates to not only your psychological well-being but your quality of life. You'll also be invited to attend regular online education and peer support group, which is facilitated by our psychologist, as well as other members of our multidisciplinary team, including the nurse specialist and dietitian. Remember that there's a natural adjustment process that happens after surgery, where emotions can be up and down. This is for various reasons, including getting to grips with the new type of diet lifestyle, as well as physically recovering from the demands of a surgery. If at any time you're worried about your well-being, please speak to your GP or contact the team here who can help you self-refer to your local talking therapy service or give you further signposting information about how to access various sources of support.
Online groups and forums. The advice provided by the healthcare professionals at Maidstone and Tunbridge Wells is all based on evidence and guidelines from BOMS, which is the British Obesity and Metabolic Surgery Society, and NICE, which are the National Institute of Care Excellence. The information we provide to you is specific to your needs and takes into account your current body size, preferences, lifestyle, and type of surgery you have. Be aware that some online Facebook groups and bariatric surgery forums may not contain evidence-based information, and it is not a one-size-fits-all approach. Often our patients support each other and swap numbers whilst in clinic or during their hospital stay, so they can text or WhatsApp each other and support and share their experiences. Frequently asked questions following surgery. How long will I stay in hospital? Most patients only stay for one night and go home the next day, but this may need to be extended if required. Will I be allowed visitors after my surgery? This will depend on the ward that you're staying on. Most of our patients recover on the short stay surgical unit, which unfortunately does not allow visitors due to its close proximity to the operating theatre, and that cause a risk of infection. How long until I can drive after my surgery? Normally a minimum of 2 weeks depending on how you're feeling after your surgery, but you may need longer. So it's always good to have somebody nominated to be able to drive you around for the first few weeks. How long until I can have a shower or bath after surgery? You can shower the day after surgery and you can bath about 2 weeks afterwards, as long as your wounds are clean and dry. We recommend that this is a quick bath to prevent any wound infections, and you're able to go general public swimming 6 weeks after surgery. Frequently asked questions following surgery. My bowels have changed after surgery. Is this normal? Yes, this is quite normal. If you are struggling with constipation, try increasing your fluids and fibre intake, and you could try a laxative like lactulose or Movicol from your pharmacy. My GP won't give me a B12 injection or continue my lansoprazole. Your GP should have received a letter from us electronically on your discharge, but you can guide them to your discharge paperwork and any letters from us. They should contact us if they have any concerns. I can't tolerate my iron tablets as they make me feel sick. Unfortunately, sometimes some people can feel slightly nauseous when taking iron tablets. Try having a double dose every other day and change the timing of them in the day. I don't think I'm losing as much weight as other people. Your journey is your own, and other people may have more or less weight to lose, different medical conditions and different lifestyles. Try and talk to your team at your next appointment. I'm struggling with my mental health. Who can support me? Speak to your GP or look at services you could self-refer to, such as We Are With You for general talking therapies or Cruise to help with bereavement. References. Please see a list below of the references we have used to make this video. NHS Choices, British Obesity and Metabolic Surgery Society, Maidstone and Tunbridge Wells NHS Trust Bariatric Patient Information Leaflet, Health Survey for England 2019, and NICE Guidance.